participants. Good afternoon and Assalamu alaikum. I would like to express my gratitude to the organizing committee of Oncology Club for allowing me to share the experiences of the TACE team of Bangladesh Society for Liver Cancer Treatment and Research of Transarterial embolization or TACE in patients with liver cancers. You know that hepatocellular carcinoma, which comprises about 85 to 90% of primary liver cancer, is sixth most common cancer worldwide, according to Globocan 2020. And it is the third most common cancer-related deaths. And in Bangladesh also the same. And it is, we see that 5-year survival is only 18%. So it is a very much aggressive tumor, I think, next to the pancreatic cancer. So in Bangladesh, you see that the prevalence it usually presents in the 3rd to 4th decades in comparison to 5th decades in other parts of the world. And in our country, hepatitis B virus is the most common cause of development of HCC on the context of chronic liver disease. So you see that the economic reasons, healthcare infrastructures, and the awareness issues, in all perspectives, we are a bit lagging behind in Bangladesh. So the patients are diagnosed in a bit late in their disease course, and so the management become a problem. So we usually diagnose on the context of a clinical complaints and their liver function tests, etiologies like Hep B, Hep C, metabolic dysfunction, acidic liver diseases or alcohol, and other chronic liver diseases. We usually do tumor markers like PIPCA2 and definitely alpha-fetoproteins. And we rely on the triphasic CT of upper abdomen or the contrast MRI. And if any conclusion is not made by these non-invasive tests, then we prescribe or do advise for tissue biopsy by histopathology. So after diagnosis, the treatment options, you know that this is all of the treatment options are surgery. If it is in earlier stage, I will show it later. And other treatment options are radiofrequency ablations or microwave ablations. And regarding transcatheter treatment, transarterial chemoembolization, transarterial embolization or bland embolization, or transarterial radioembolizations. And the radiation therapy, we can prescribe some patients for SBRT. And lastly, the systemic therapy, which includes sorafenib, benvatinib, and newer, you know, that immunotherapy. So this is the pictorial view of the RFA or microwave in the above slide pictures, and the middle is TACE. You see that the drug is delivered, chemotherapeutic agents is delivered to the feeding vessels of the tumor, and then the embolizing agents is delivered to block the vessel and to block the nutrition so that we can get the control over the tumor. So we know that regarding liver cancer management, BCLC staging is very much important, followed all over the world. And in early stages, like in BCLC 0, you see that the single lesion, if it is less than 2 centimeters, then the options of management is ablations or resections. But if in later stage or in early stage, BCLC A, the size a bit increased, but it is less than a single lesion less than 5 centimeters or 3 lesions, each one less than 3 centimeters. You can prescribe or patient can be advised for liver transplantations along with liver dissections. And later on in BCLC stage B, which is the intermediate stage, the option of treatment is transarterial chemoembolization. And also, if any patient is unwillingly to do or liver transplantation cannot be possible, then BCLC A can also undergo transarterial chemoembolization. And the BCLC C and D, you see that the in C there is portal-vein invasion usually is there, so TACE cannot be possible or contraindicated. And for those patients, systemic therapy can be prescribed according to patient's general conditions, performance status, and liver functions. And in BCLC D, only palliative therapy is the option. So 2 options are here. One is conventional TACE, and another one is DEP TACE. So what is conventional TACE? In conventional TACE, we put the drug, chemotherapeutic agent, usually doxorubicin. Other chemotherapy drugs can also be given, like cisplatin or irinotecan. These drugs can be used in other indications also. We usually use doxorubicin as chemotherapy drugs, and the agents, embolic agent is used as are usually lipoidol. So this is called conventional TACE. And another one is DEB or drug-eluting bead test. TACE, this is the substances which provide, they will release the drug gradually over time. So there is fewer systemic side effects in relation, in comparison to CTACE. So to analyze the clinical outcomes, survival predictors, and to assess the efficacy of TACE as a treatment modalities, and to see any factors influencing the survival, we had a study was done. It was a retrospective study. It was done on 82 patients with hepatocellular carcinoma who undergone TACE in the period of 2016 to 2024. Patient was selected by purposive sampling after meeting the eligibility criteria, and the treatment was given either conventional TACE or DEB TACE, and endpoint of treatment was subjective angiographic chemoembolization or SAGE, and all the patients before going to TACE, a multidisciplinary tumor board was done. The patients were hepatocellular carcinoma with chronic liver disease due to any cause, patients with BCLC stage A to C, and compensated liver disease, definitely child by A or B, and ECG performance status was 0 to 1. These were inclusion criteria. And the patients having serum bilirubin more than 3 milligram per DL, creatinine more than 1.5 milligram per DL, and having portal vein thrombus or biliary obstructions and extrahepatic spread, these patients were excluded from the study. The socio-demographic data, clinical, laboratory, and the treatment data were analyzed. Two type of TACE, you see that CTACE was given in 53% of patients, 40% patient received DEB TACE, and 7% patient receives only embolization without any chemotherapeutic drug, that is bland embolization. So we saw that survival data, the 1 year survival was 68.3% patients. They survived more than 1 year. 2 year survival was a bit less, and it was 13.4%, and 5 year survival data was only 2.4%. The mean age, BCLC stage, CP scoring, and ECOG score were compared in between survivors and non-survivor, among these two groups. So we see that in that albumin level, so it was observed that higher albumin level was observed in survivor group in comparison to non-survivor group, and this was statistically significant. Other investigations were also compared among survivor and non-survivor group. It included the ultrasonogram findings, enrollment of lobes, and number of nodules. Also the esophageal varices and FNC findings. Among these was not clinically significant, but in our observation, the conventional TACE had good results. That is, patient survival was more in conventional TACE group in comparison to DEB TACE. So with regression analysis, we found that serum albumin status and BCLC stage of HCC, this independently predicted the survival. But supportive care did not benefit survival as compared to other treatments. So in discussion, we can say that the TACE is significantly improved survival in early stage HCC, especially BCLC A and B. Survival predictors were younger age, BCLC early stage, CHILPA A, is ECOG 0, that means performance status was good, and higher serum albumin level. So patient selection for TACE could be optimized, the better outcome. And the biggest challenge was maintaining the long-term follow-up. As the patients, we saw that much patients were, we have lost in the follow-up. So the recommendation from this study was hepatitis B and C screening, and you know that also fat liver screening is important to early detection and treatment. The TACE facility is still now in the central areas, and if we can expand this to the rural or suburban areas, that will be more beneficial for the rural peoples. Registry keeping is very important. That is, national liver registry should be maintained along with electronic data keeping. That will help us for tracking the outcome. And future direction should be the study of TACE alone or in combination with immunotherapy, or TACE in combination with microwave ablations or other systemic therapies. So in conclusion, I can say that early diagnosis and treatment escalation can significantly improve outcome in patients with hepatocellular carcinoma. Health services could allocate more resources and training to facilitate access to TACE in rural or suburban areas and add valuable years to life. With these words, I would send you the greetings from the Bangladesh Society for Liver Cancer Treatment and Research, headed by Professor Selimur Rahman. And we have Dr. Fazil Karim is here. He's head of hepatology of Medford Hospital. And we have intervention radiologist, Dr. A.K. Moinul Hussain. And we have dedicated anesthesiologist in our team. With these words, I would like to thank you all for patient hearing.
Thank you, Dr. Faroque Ahmed, for sharing valuable data on hepatocellular cancer management.